Hey everyone, good morning. We're going to get started. Today I have the pleasure of introducing Dr. Maria Giovanna Trivieri. Dr. Trivieri received her medical degree and PhD from the University of Pisa. She completed her internal medicine residency and her cardiology fellowship at the University of Toronto and her advanced heart failure and transplant fellowship here at Mount Sinai. Dr. Trivieri is a Department of Defense funded investigator who has extensive experience studying cardiac physiology. Her research focuses on the signaling pathways that are dysregulated in heart failure and pulmonary hypertension. She has a very active clinical research portfolio focused on the use of hybrid imaging modalities for the investigations of cardiomyopathies, recently becoming the lead PI of a large NIH grant. She also has a strong record and interest in mentoring trainees. Please join me in welcoming Dr. Trivieri.
And good morning, everyone. It is really a pleasure to be here today. I wanted to express my thanks to the Department of Medicine for inviting me. So my objective in the next hour or so is to provide you with an overview of my research portfolio, which spans the field of cardiomyopathies and pulmonary hypertension. And I will be focusing particularly on the use of PET-MRI for the evaluation of this condition. And for those of you that are not familiar with this technology, PET stands for positron emission tomography, and MR stands for magnetic resonance imaging. So as was already described, I come a long way from Italy, then went to University of Toronto, and finally I landed at Mount Sinai. It's been a long journey, full of exams. You can imagine lots of different testing to get my accreditations, but I'm glad to be here. It's been a fabulous journey. And presently, I have a dual appointment in the Division of Cardiology and the Division of Radiology. And I also lead the local pulmonary hypertension program here at Mount Sinai. My research portfolio focuses on, again, as I mentioned, cardiomyopathies and pulmonary hypertension. And I have a clinical research area as well as a more preclinical focus. So I have a lab actually located on the 8th floor of the S building. And again, focusing primarily on cardiomyopathies. For the clinical research, as you will see throughout the course of my presentation, I mostly use PET-MR with different tracer like sodium fluoride or FDG. And the pathology that I am concentrating in particular are sarcoidosis, mitral valve prolapse, and amyloidosis. For my preclinical work, again, it's wet lab research, I use iPSC-derived cardiomyocyte starting from cells that are genetically engineered and model this disease. I will not be speaking about that, hopefully another time. And my work has been consistently funded throughout the year by the AHA, the NIH, and also the Department of Defense. On the pulmonary hypertension side, I also have a clinical area of interest which focuses again on the use of PET-MRI, as well as a preclinical interest which uses induced pluripotent stem cell carrying various kind of genetic condition linked to pulmonary hypertension. And with this iPSC, I generate both endothelial cell and smooth muscle cell. And more recently, I've been able to create vascular organoids. Again, a more of a wet lab research area that I can talk about in another presentation. So those are some of the grants that I have been the PI on. I'm also an advisory board member for some of the company that produce the drugs that I use for the management of my PAH patients. So the objective in the next hour or so is to present some of the diagnostic dilemmas that we have in the evaluation of cardiomyopathies and pulmonary hypertension, and discuss how the use of PET-MRI as a novel imaging modality can be useful in the evaluation of this condition. So what do we mean when we talk about cardiomyopathy? Cardiomyopathy, according to the position statement from the European Society of Cardiology, is defined as a myocardial disorder where the heart is structurally and functionally abnormal, but there is no coronary artery disease, hypertension, valvular heart disease, or congenital heart disease that's enough or sufficient to result in the observed myocardial abnormalities. So essentially what it means is that every time we label somebody as having a cardiomyopathy, we need to make sure that the patient doesn't have any of the aforementioned condition. So if we exclude those conditions, what are essentially the cause of the cardiomyopathy that can be responsible for the phenotype we are seeing? Obviously, gene, either a single gene or cluster of gene. We can think about epigenetic dysregulation. We don't have presently anything that's been linked specifically to epigenetic dysregulation in the cardiomyopathy field, but you can think that that's potentially one of the mechanisms. You have the unspecified inflammatory and autoimmune myocarditis like sarcoidosis. You have cardiomyopathies in the context of systemic disease, for example, end-stage renal failure or anemia. Or you can have cardiomyopathies resulting from the exposure to toxin and pathogen, like, for example, Chagas cardiomyopathies or iron overload cardiomyopathies. And then obviously there are the unknown. And I think it's important to remember that because the extent of what we know about a patient and the unexplained cardiomyopathy goes along with the depth or the phenotyping that we do. And this is a study that I like to always quote from 2000, published in the New England Journal, where they actually looked at approximately 1,200 patients that had initially an unexplained cardiomyopathy, and they conducted a thorough workup of this patient. And you can see that at the end of this thorough workup, they were able to find the diagnosis for this cardiomyopathy, which was considered initially unexplained in 50% of cases. And in this area, like in this table, you can see that aside from the idiopathic, some of the cardiomyopathy that often are diagnosed or discovered, if you do a very extensive workup, are obviously the familiar one, the sarcoidosis, the amyloidosis. But just the point is that you need to essentially do a very thorough workup before you kind of conclude what the cause of the disease is. So where is imaging potentially helping us? What is the role potentially of imaging in helping us with the evaluation of cardiomyopathies? I see imaging as the closest tool we have to in vivo analysis of molecular pathway. And that is the reason why I think it's so powerful, and that is the reason why I think especially PET is so powerful, because you can think about the possibility of using different tracer targeting different molecular pathway to actually diagnose disease. So my idea long-term would be to actually develop a system where you can comprehensively, using PET-MR and dedicated tracer for PET, identify the presence of disease. These are images showing, for those of you that are not familiar, this is an MR, that's late gadolinium enhancement. And the signal that you're seeing here is a PET signal. So ideally, if you have a PET signal that is labeling a specific pathway, and you can have the MRI that can tell you about the structure function of the heart, you can, with one single modality, identify disease, have a specific diagnosis, and also have information on disease activity. And again, this is from a patient that was diagnosed with sarcoidosis. And if I did not do the PET, and I only did the MR on this patient, what I would see is the presence of late gadolinium enhancement. But by coupling it with the PET, I can see that the patient has also significant uptake in the area where there is LG. So I can, with the same, with one imaging modality, essentially diagnose disease activity. And what I'm hoping to do is also identify specific pattern on imaging that are specific to certain condition, like in this case, sarcoidosis. And this sign that you can see seems to be quite pathognomonic for sarcoid. So my first interaction actually with PET-MRI as a tool came when I first came to Sinai. It was around 2015, 2016. And at that time, there was a lot of research being done in the field of cardiac amyloidosis. And you might recall that around the same time, there was a lot of work being done with the tracer that were able to detect amyloid. So we decided to try a tracer specifically, which we felt could be useful in the diagnosis of amyloidosis. And the use of tracer in amyloid came from some of this seminal work that was done mostly by group in Italy. You can see in 2005, 2011, 2014. And this initial study had shown that using bone scintigraphy tracer was very helpful in enabling you to diagnose essentially cardiac amyloidosis. This is a slide showing a patient with AL amyloidosis. You can see no uptake in the heart. And this is a patient with ATTR amyloidosis showing a clear uptake in the heart. And the data that was coming up was showing that actually this particular tracer, this phosphonate technetium bisphosphonate, was particularly sensitive and specific for ATTR. We don't know exactly why. It's linked to calcium cycling, so it's not clear why it's certain form of amyloidosis. This tracer is taken up from the heart. So starting from that, we went along and decided to use a similar tracer to the pyrophosphate or the bisphosphonate called sodium fluoride, which likewise the bisphosphonate seems to link to sort of identify area that have enhanced calcium activity. And what we did, we subjected some patients that had ATTR amyloidosis and AL amyloidosis to scan with this new tracer called sodium fluoride. You can see in the slides shown here that when we did the MR, this actually on the left is the MR, in the middle is the PET, and on the right is the overlap between the PET and the MR. Because just going back for 1 second, when you do the actual PYP scan, you are able to identify uptake, but the PYP scan doesn't give you information on the presence of late gadolinium enhancement or amyloid deposition in the heart. You don't see the heart structure with pyrophosphate. With MR, so you would still need to do an MRI to identify that. With pyrophosphate, with PET MR, we can have information on the deposition of amyloid in the heart and simultaneously detect the presence of tracer uptake. So you can see in the slides on the left, essentially, both patients with ATTR and AL show evidence of amyloid deposition or late gadolinium enhancement. This is a signal that we see on the MR. But if you compare this patient with the other one, in the first patient, there is significant uptake of sodium fluoride in an area where there is LG, and there is no uptake in AL. And this is the overlap image. So essentially what we did show is that by doing one single test, we were able at the same time, what's going on? We were able at the same time to diagnose, type, and quantify. And we measured, because the beauty of PET is that compared to the MR, which cannot be quantified, you can actually quantify the amount of tracer that is deposited in the heart, which I think can come particularly useful right now when we have disease-modifying therapy, where if you only use the LGE to detect the presence of disease, you will not be able to know how much resolution of LGE is there. But if you actually quantify the amount of tracer uptake, you can say, well, this patient, after receiving this therapy for amyloidosis, has had a reduction of signal by 40–50%. Because again, as shown on the right, we're actually able to quantify this signal. And the parameter that we use typically in PET are SUV, which tells you about the uptake, the amount of uptake, and TBR, which is a normalized value of the uptake. And when we calculated the TBR, what we did see was that the TBR value was significantly higher in ATTR compared to AL. So we published this study, but you can see what the value potentially of this modality is compared to the PYP scan that we are currently doing. Because with the PYP scan, you can obviously detect the presence of amyloid, but you would not know how the heart look on MR, so you still need to do an MRI. And you will not be able to observe or monitor for changes in quantity of amyloid. So a very powerful modality that I think will have a lot of potential in the future. And we are actually expanding on this work, and I'm in collaboration with Dr. Kantorovich, who has specifically an arrow 1 on that, looking at carrier of the ATTR mutation, which is one of the mutations associated to hereditary amyloidosis. And she identified those carriers in the BioMe biobank. We are actually looking at comparing the standard of care imaging modality that we currently use to detect amyloidosis, like the transthoracic echo, the PYP scan, and compare that with PET. And we are finding a lot of interesting results that we hopefully will be able to publish soon. So for this particular work, we are not using sodium fluoride as a tracer. We are using actually another tracer called Amyvid, which is labeling not just, we think, AL amyloid, but also ATTR. So we'll need to see how it differs between the different forms of amyloidosis. So this is just an overview of the work that we are doing on amyloid using PET-MR. What about sarcoid cardiomyopathy? We have done a lot of work here at Mount Sinai on this condition using PET-MR. You are very familiar with the fact that sarcoidosis is considered an inflammatory cardiomyopathy. Unfortunately, despite the fact that people, talk about a certain number of cases that have sarcoidosis, not sarcoidosis, we still don't have a specific diagnostic biomarker that it's either qualitative or quantitative. So it remains a diagnosis of exclusion. And we don't understand really what is the pathophysiology, whether it's genetic or environmental. There is also an unpredictable course and response to treatment. And the other complicating factor is the fact that it can be present without disease elsewhere. If you have sarcoidosis in the lung, then you identify in the heart. The association and the diagnosis of cardiac sarcoidosis is easy, but we find a lot of times that we identify, on pathology, evidences of sarcoidosis in the heart without disease elsewhere. So this is often a very challenging diagnostic dilemma. But I think to me, the most pressing issue is really the fact that we don't have a biomarker that we can use. There's nothing we can use to say, oh, this patient has sarcoidosis, this patient has 50, like in response to treatment, has had a reduction of 50% in the amount of inflammation. We have a very qualitative and sort of very rough way of characterizing, quantifying the disease. Despite the fact that people sometimes seem very sure about the diagnosis, it's really usually not it's really a speculation because we don't know specifically what it causes and how to diagnose it. But in the literature, if you read about it, what you'll find is that in patients that have sarcoidosis elsewhere, not the heart, like for example, lung sarcoidosis, which is the most common phenotype of sarcoidosis, up to 5–10% of patients typically are diagnosed with cardiac sarcoidosis. As I mentioned earlier, it can be present without any form of, any other clinical disease, manifestation of clinical disease elsewhere. We know that the cardiac involvement is often underestimated. As I said, it represents a diagnostic dilemma, and I'll go over that in a second. And this is despite the fact that steroids have been shown in some cases to improve prognosis if started earlier. I don't know. Okay. So how do we diagnose sarcoidosis right now? We think of endomyocardial biopsy as the gold standard for this condition. Essentially, we need to prove that the typical pathognomonic feature of sarcoidosis is non-caseating granuloma. So we need to find this non-caseating granuloma in the heart or elsewhere. Unfortunately, in the heart is often the case that we don't identify that. So we typically the workup is a patient presents with an unexplained cardiomyopathy. They have a cardiac MRI. They're finding suggestive of sarcoidosis on the cardiac MRI, and we try to do a biopsy. And very often, we don't identify any non-caseating granuloma in the heart because the disease is patchy. So sometimes it can involve the lateral septum, the lateral wall of the ventricle. Sometimes it involves the anterior wall or the posterior wall or the RV. And because there is a variable location, you can imagine how unpredictable also our diagnosis can be by endomyocardial biopsy. Indeed, if it does involve the posterior wall, we often don't diagnose it by biopsy because this is an area that is not accessible to biopsy. Likewise for the anterior wall. And we also know that echocardiography is neither specific nor sensitive. Sorry. And also electrocardiography, again, there can be block, which is often a clinical presentation of sarcoidosis, but again, nothing is really specific for the disease. And often when we talk about sarcoidosis, we refer to sarcoidosis as the great mimicker. And why do we think of the sarcoidosis as the great mimicker? We think of that because really the presentation as well as the imaging finding of sarcoidosis can overlap with a lot of other different conditions, such as myocarditis or ARVC. And if you look at the clinical presentation of cardiac sarcoidosis, myocarditis, and RVC, there is a lot of overlap. So they all can present with essentially sudden cardiac death or heart failure or AV block. Although AV block tends to be more rare in ARVC. Typically, we think of myocarditis as a condition triggered by a viral infection. So you can have a viral prodrome in patients that have myocarditis. But very often, when a patient presents to us, the viral prodrome has subsided. There can be a lot of lag between the initial presentation and the actual testing. So it's not necessarily a tool that can help. It can be useful. On MRI, we often find similar findings like LGE, which is late gadolinium enhancement, which is a marker of scar. For the cardiac sarcoidosis, we can have increased uptake of FTG, but that can be also seen in non-specific myocarditis. Also in ARVC, sometimes we look at the location of the scar to differentiate one form from the other, but again, the sensitivity and specificity of that can be sometimes very poor. I alluded to the fact that we don't really have any serum biomarker that we can use to diagnose sarcoidosis. For myocarditis, again, if you think of it as a viral triggered condition, a lot of time you can have more of an acute presentation with chest pain syndrome, so elevated troponin, elevated ESR, but that's not, again, always the case. And then part of the diagnostic workup involves doing an endomyocardial biopsy or genetic testing. For the serum biomarker, you might have probably read or heard that there are a lot of being used or thought of as specific to sarcoidosis, like ACE. But if you look exactly at go into details, you'll see that the sensitivity and specificity of all of these serum biomarkers is not adequate to rule in or rule out the condition. So a lot of work has been done, but there is no serum biomarker that we can actually say for sure causes sarcoidosis. And it is the reason why, because we don't have a serum biomarker, the HRS, which is the Heart Rhythm Society, and the Japanese Society came up with some criteria to diagnose sarcoidosis that essentially take into account the challenges that we have with this diagnosis, and I'll go over those. The Japanese criteria, I'm not sure you are familiar with that, but there is a high prevalence of cardiac sarcoidosis in Japan for a reason we don't know. Were originally published in 1993. They were modified in 2007, 2017, and they do require either histological confirmation or a combination of what they call major and minor criteria, or some laboratory findings. The Japanese criteria don't require a diagnosis of sarcoid anywhere else. So you can essentially make a diagnosis of sarcoidosis using the Japanese criteria just based on the major and minor criteria. And because it don't require essentially histological confirmation of sarcoidosis, not just in the heart, but anywhere else, they're felt to be less specific. The HRS criteria, which are the criteria that we usually follow, instead require histological evidence of sarcoidosis. Obviously, if you have sarcoidosis in the heart, you would be able to diagnose somebody with cardiac sarcoid. But if you don't have sarcoidosis in the heart, you need to have proof of extracardiac disease, meaning you need to have sarcoidosis anywhere else. It can be in the skin, can be in the lung, can be in the eye. And then you need to have evidence of cardiac involvement in the form of essentially like unexplained cardiomyopathy or heart block or evidence of abnormalities on PET and MR. But the most important thing is that we need to exclude, accordingly to the HRS, any other cause of granulomatous disease. And according to some expert in the field, So there are some experts in the field that actually think that this is not possible because the amount of workup that would be required to exclude all the possible causes of non-caseating granulomatous disease is essentially immense. And this is just an example of the many different things that when you see a patient with sarcoidosis, you would need to think about. So even if you have a non-caseating granuloma, you find it in the lung, you will need to essentially exclude. I'm sorry, it doesn't show very well, maybe you can see. You need to exclude exposure to particle, organic, inorganic particles. So you need to do such an extensive workup that some sarcoidosis experts believe that essentially you can never be sure somebody has really sarcoidosis. So is there any better way to actually make the diagnosis? And again, keeping in mind the fact that we don't really have a good understanding of the disease pathophysiology, I think that maybe one easier way, I don't think it necessarily is the best, but one easier way to diagnose sarcoidosis would be to combine different imaging modality within one single test. And we have done some work showing that the combination of PET and MR using FTG, which is a sugar analog, looking particularly at the distribution of the scar, the location of the scar, the intensity of the signal can be maybe better in identifying sarcoidosis, with the caveat again that you can always argue, well, does this patient really have sarcoidosis? But we think that the combination of PET with the FTG and using both qualitative and quantitative parameter can give us some more guidance in having probably a better assessment of the patient. So we did conduct a lot of work because, as you know, Mount Sinai is actually a center of excellence for sarcoidosis. Dr. Morgenthau lead the sarcoid clinic here at Sinai. There's a long history, a long tradition of working with sarcoidosis. So we have had the fortune of having a lot of patients with presumed sarcoidosis being referred for evaluation. And we started looking at way of using PET-MR and qualitative and quantitative parameters to actually better define the disease. Because as it is right now, it's a yes and no phenomenon, meaning patients either have disease and it's active or they don't have disease. But we don't have anything in between, and we don't have anything that allow us to sort of monitor, follow patients over time. So with PET-MR, we can actually go into more granular evaluation of the structure function of the heart. We can look at location of scar. We can look at distribution of the signal. And those are some of the way we try to do that. You can see here we classified patient as being MR positive or MR negative. And then we looked at the distribution of the signal, whether it was focal or was focal on diffuse. And then we conducted a number of quantitative assessments. So we are trying to shift the approach from a very qualitative to a more quantitative, so it can be more useful perhaps in the clinical evaluation. And some of the things that we do that I mentioned earlier is measure the intensity of the signal using SUV and TBR, and another parameter that we introduce in the literature, which is TNR, which is target to normal myocardial ratio. And we also quantified a lot of the standard MR parameters, which you probably have heard of, including T2 mapping. And by doing this quantitative evaluation that includes all these parameters, this is just an example of the very different metrics that we can use with PET-MR, we have been able to somewhat have a more accurate assessment of the patient and predict outcome. And what we did see is that if patient had a combination of PET activity and MR findings, like they were, as in these slides, both PET positive and MR positive, you can see this is the LGE, the scar, this is the uptake of FTG, and again, similarly scar, FTG, and PET signal. When there was an overlap between the PET and the MR, that had higher odds ratio of predicting outcome. And likewise, when we used this TNR parameter, we found that it had higher sensitivity and specificity for quantifying clinical outcome. So I think there is still a lot of work to be done in this field, but I think that combining a more precise and accurate assessment by imaging on the disease and both activity and location, we can maybe be better at predicting outcome in this patient. I'll just switch gear right now and talk about the potential usefulness of PET in other conditions that we have studied here at Sinai, including transplant rejection and LVAD infection. Obviously, for LVAD, we use CT, so I won't talk about that, but I will go and describe a few cases that we characterize using PET-MR in transplant, and some of my colleagues are here. So we know that for cardiac allograft rejection, the gold standard is considered to be endomyocardial biopsy. However, we all know that, like any biopsy, is prone to sampling error, and there is an associated morbidity with that. We can think about other imaging modality like PET. But one of the problems with PET and FTG is a sugar, is that sometimes patients don't follow the dietary preparation. You might have had some reports that says, oh, patients didn't follow the low sugar, low carb diet. And sometimes there can be ambiguous result with the FTG. MRI is really challenging immediately post-transplant, primarily because there can be a lot of changes, especially in the form of edema, swelling in the heart, that make the technique not particularly sensitive and specific. So how about other tracers that are more specific to inflammatory cell? Again, because we have been playing around with a lot of the tracer and the PET, we thought of using another tracer in this condition to look at rejection. And we particularly focused our attention on dotatate. You might have heard about dotatate, which is typically used to diagnose neuroendocrine tumor. It's one of the tracers that you use for this condition, but it is a somatostatin receptor. And it's felt to bind specifically to inflammatory cell and to be able to visualize early lymphocytic infiltration in the myocardium, and could be considered as a surrogate if you think that a rejection is due to inflammatory infiltrate of rejection. And what we did see was that when we searched the literature, we observed that there were some preclinical data looking at the use of dotatate in a rat model of rejection. So we went ahead and designed a pilot study looking at specifically gallium dotatate and hybrid PET-MR for the non-invasive detection of our transplant rejection. We particularly focused on those patients that had biopsy-negative rejection, but where the clinical diagnosis was highly suspicious for rejection. So the patient presented with heart failure, for example, but the biopsy was negative. And we scanned a total of 4 patients, 1 control, and 3 patients that had suspected allograft rejection that were presenting with heart failure. And I'll just go over one representative case that I think is very informative. This was a male, 60 years old, was 13 years post-transplant. He was admitted with acute heart failure. He underwent a biopsy that showed that the patient had cellular rejection, grade 1R. He underwent treatment for rejection, which is usually high-dose immunosuppressive therapy, and had a repeat biopsy, which was negative. So he underwent at that point in time, and we were lucky enough to capture that, a baseline gallium dotatate scan. And you can see, just to orient yourself, this is the PET. There is no uptake of dotatate. This is the matching MR. There is no signal that you see. And just to orient yourself, this is the right atrium, right ventricle, left atria, okay? 6 weeks later, the patient presents again with recurrent heart failure symptoms, elevated troponin. It also has AV block. So we do repeat a PET-MR with gallium dotatate, and what we do see in the repeat scan after 6 weeks is significant uptake in the lateral wall and along the AV septum. So the biopsy was negative, and that was not surprising because you can see that in the septum there is clearly no uptake. Because when we normally do biopsy in transplant patient, we biopsy the interventricular septum. But the patient has had uptake essentially in an area that were not accessible to biopsy. So with the gallium dotatate scan, we were able to identify area that were inaccessible to biopsy, but showed infiltration with the tracer. And we were able to show also there was a very good correlation between the uptake of dotatate and clinical event. And indeed, the patient had the AV block, as I mentioned, and there was significant uptake along the interatrial septum. So we are doing additional work on that to try and understand how this modality, so we are hoping, we submitted actually a small RR21, but I don't know whether it's going to ever be reviewed in February, but I don't know. But we are hoping to continue to work on, on the use of this tracer, because I think it has a lot of potential to look at the heart as a whole, as opposed to just look at one area, which is the interventricular septum. And I'll move along. The last part of my slides is about presentation is about the work that we are doing in collaboration with the Cardiothoracic Division here at Mount Sinai, with Dr. David Adams, with the Electrophysiology Department, Dr. Mark Miller, and with the Imaging Department, Dr. Zahi Fayyad. So we recently awarded a large NIH grant to study this. Mitral valve prolapse, as you might be familiar, is a very common condition and carry a risk of sudden cardiac death. Unfortunately, we are unable to tell right now. There are some features that are considered to be higher risk for sudden death, but we don't have a way to specifically risk stratify patient. And because of all our experience with working in the field of sarcoidosis, which you know is an inflammatory condition, we initiated this pilot study looking at the potential utility of PET-MR also in mitral valve prolapse. The leading hypothesis was that similarly to sarcoidosis, also in mitral valve prolapse, there could be maybe inflammation that precedes the development of scar that can be independently linked to risk. So a question was essentially, is subclinical inflammation, which is known to be pro-arrhythmogenic, potentially part of the disease of mitral valve degeneration? And again, we conducted a pilot study to look at this question. The question that we had in mind was whether or not the progressive development of fibrosis was preceded by inflammation. We know, in fact, that there are patients that don't have LG that develop LG. Is this, is just a natural history of the disease? We also know that the presence of LG is not the only reason why. Sometimes you can do an MR on a patient, they don't have LG, they can still die. So there are situations where even patients with minimal fibrosis or no fibrosis can develop, essentially can experience sudden cardiac death. So it's not that necessarily you need to have fibrosis to have cardiac death, sudden cardiac death. So there's a possibility that maybe those patients have inflammation. And we know that there is often an out of proportion, there can be situations where the amount of ventricular ectopy that you see when you do an Holter on this patient is out of proportion to what you see on the MR. So again, we conducted this pilot study, and we initially looked at patients that had severe MR, and all these patients underwent simultaneous PET-MR. And what we did see, to our surprise, again, it was nobody had ever used this modality in mitral valve prolapse, was that this patient had a high prevalence of both PET signal and MR for the most part. And interestingly, when we divided patients into those that had complex ventricular arrhythmias and minor ventricular arrhythmia, what we did see is that in patients that had more complex ventricular arrhythmia had more higher percentage of LGE, and the patient that had more minor ventricular arrhythmia, again, had less LG and more inflammation. So again, suggestive that, there is a time course of the disease that we can maybe track with PET-MR. And those are just some of the slides. Again, you can see the left ventricle, there is scar, there is inflammation, likewise scar and inflammation. So clearly a very localized signal that we are seeing. And we are in the process of, again, further expanding on that. And that is the grant that we got that essentially is looking at two different groups of patients. Group one that we call the surgical cohort that have planned undergoing mitral valve repair as part of their surgical care. So these patients are essentially enrolled in the study, and they undergo two different scans, one at baseline, which is a PET, actually two scans at baseline, one with FTG and one with dotatate, because we also want to understand if the dotatate potentially is even a better signal compared to the FTG, because we know that dotatate, and we have had this criticism from some of the reviewers, because some say FTG is really a marker of sugar utilization. So it can be also taken up by the myocyte. How do you know that it's not, it is really specific to inflammatory cell? So as part of what we are doing in the study, we are looking essentially at using these two tracers, dotatate and FTG, in the surgical group. So these patients undergo two PET scans. And then they have surgery by Dr. Adams, and at the time of the surgery, we actually map the area of inflammation that we see on the PET. So Dr. Adams collects a biopsy, and then we analyze the biopsy to try and understand the correlate between inflammation and, or the signal on PET and inflammation. And then we have a non-surgical cohort of patients that includes patients with less than severe MR that don't have a surgical indication. And those patients will undergo serial testing on a yearly basis to see, how the signal on PET correlates with progression of disease. And just touching upon the fact that we have also used, of course, PET-MR in evaluation of long COVID here at Sinai, and this is a long collaborative work that we have had a lot of problems getting published. It's still not published, but despite it's becoming very difficult to publish anything related to long COVID, and I think, I can understand some of the issues. But what we did see, we essentially scanned patients that were up to a year from the onset of COVID and had persistent cardiopulmonary symptoms in the form of shortness of breath and palpitation. They were referred to us by either a pulmonologist or a cardiologist. So this was not a community-based sort of assessment. They had undergone baseline testing as routine standard of care. And what we did see is that there were abnormalities on PET-MR even at 1 year from the onset of COVID. In up to 20% of these patients. And we did characterize different pattern of inflammation that included myocardial uptake in the form of myocarditis. We did see coronary uptake. This is the left main. We did see a lot of inflammation in the vasculature, both the pulmonary artery and the aorta. We did see pericardial uptake, even at 1 year. But I think the most interesting thing that we see, and I'm glad Dr. Chen is here, is evidence of periannular uptake. So uptake around the annulus of the mitral valve. We know that, for example, group A strep is associated to long-term development of mitral valve stenosis. There was a percentage of patients that had evidence of uptake around the annulus of the mitral valve. Again, we don't know, it was just a one-time point evaluation, but we did see this different pattern of uptake. And this is some work that we are doing in combination with many different individuals within the Mount Sinai group. So it's a very collaborative work, which we hopefully will publish soon. And again, so our speculation is that long COVID essentially, or COVID indeed, as a general condition, should be considered as potentially a risk factor for the development of heart failure, vascular disease, and even valvular disease. So it should be part of the evaluation. Obviously, we don't have all the data to prove that, and I have to mention that we have also done biomarker analysis in this patient, and patients that had abnormalities on PET-MR actually had abnormalities also on biomarker that were distinct from the other population. So there is an inflammatory component that peripherally can be captured regardless of the PET. So we do think that there are some patients that are at risk of this long-term complication. The challenge is that we did one time point. What we wanted to do with this paper is raise awareness about the condition and the need in some specific subgroup to do additional testing to exclude those long-term sequelae. Then I'll conclude and be very quick on the last part of my talk. We also have been working on the use of PET-MR in pulmonary vascular disease. And again, I won't talk about my iPSC work. We know that there is a lot of association, it's a known association between pulmonary hypertension and inflammation. So this is essentially some of the evidence linking inflammation to the pathophysiology of pulmonary hypertension. So naturally, since we are using PET-MR, which is a tracer for inflammation, we also felt that it could be applied to this condition as well. And I think it's particularly relevant because when you talk about pulmonary hypertension, I know I won't have time to discuss that, but we don't follow the vascular remodeling in the lung. We do look at how the patient changes in response to therapy in terms of functional status. We look at the response of the right ventricle. We look at the improvement in walk test distance, but we don't actually measure or quantify vascular remodeling. We have no way of doing that. We don't do biopsy of the lung. So potentially, there is a lot of room eventually of using some more sophisticated technique to actually see the remodeling in the lung. And again, we were lucky because by doing all these PET-MR in patients with sarcoidosis, we came across some patients that had sarcoidosis, and we noticed had evidence of uptake along the pulmonary tree. So we distinguish some of those patients as having positive uptake in the pulmonary artery and no uptake in the pulmonary artery. And again, these images just show you how clearly it is when patients have uptake to identify that. Those are images, coronal slides. You can see the pulmonary artery, the right pulmonary artery here. You can see a lot of signal uptake along the right main PA. Those are essentially axial view where you can see the pulmonary artery, the aorta, the two branches, and this is a caudal to cranial projection. So there were some patients with sarcoidosis that we were evaluating for cardiac sarcoidosis that clearly had evidence of this uptake in the pulmonary artery. So we went ahead and looked at those patients in particular, and specifically the one that had evidence of uptake in the pulmonary artery that had also undergone right heart catheterization as part of the standard of care. And what we did see is that in patients that had evidence of uptake in the pulmonary artery, all of them that had uptake in the pulmonary artery had essentially a diagnosis of pulmonary hypertension. So there was 100% specificity in diagnosing pulmonary hypertension. And the dotted line refers to the old cutoff we used to use for pulmonary hypertension, which was 25 millimeters of mercury, and the red line to the new cutoff for pulmonary hypertension, which is a mean PA pressure greater than 20. So you can see that all patients that had uptake, essentially, they had on right heart cath evidence of pulmonary hypertension. And there was the same, obviously, there was also correlation with pulmonary arterial systolic pressure, diastolic pressure, and PVR. And again, very close correlation between SUV, PR, and SUV, which is the marker of intensity of uptake, and the degree of pulmonary hypertension. So very powerful. So you can technically think about the possibility of doing a PET in these patients. You diagnose and identify signal intensity in the pulmonary artery, you measure the intensity of the uptake, and you derive from the intensity of the uptake that you measure actually the degree of pulmonary hypertension. So potentially a lot of it can be very useful in tracking disease because it's quantitative. So you can think about the possibility, for example, of scanning one patient, then starting them on therapy, then following up with the PET at a year or 2 years and see how the signal intensity, the remodeling within the pulmonary artery is taking place. And again, also a lot of correlation between intensity of uptake and degree of RV dysfunction. We did this initial study actually in sarcoidosis because this was the population that we initially characterized. But we also looked at other patients that have pulmonary hypertension. So it doesn't seem to be specific to sarcoidosis. It's a reflection of essentially a remodeling in the pulmonary artery. And on the top is a patient with PH, idiopathic actually pulmonary hypertension. And at the bottom is a patient with connective tissue disease associated pulmonary hypertension. So I think, again, and we only used FDG to study this condition, but you can think about the possibility of, for example, looking at pH with dotatate and see what is the effect, what is the remodeling that is taking place with those therapy, and how each different therapy is affecting the response. So to summarize, I hope I haven't bored you too much, but I think that PET is a tremendous tool. We should start thinking about PET as a way of tracking pathways and pathophysiology in vivo that is clearly underutilized in both cardiomyopathies and pulmonary hypertension. I think the strength of this modality is primarily in the fact that it can be coupled with any different tracer, so it can label any different pathway in the future that you want to check, you want to monitor. Obviously, this work would not be possible without the support of all the agencies that have, provided the resources for this work. All the people, some of them are here, my colleagues from the heart failure division, my colleague from the imaging department, and everyone else that has worked with me. So thank you very much, and that concludes my talk. Thank you.